Assalamu alaikum. This is Yumna Nadeem, roll number BP1450214, presenting you my topic that is drug fever. Let's start with introduction. Drug fever is a febrile reaction induced by drug without additional clinical features like skin eruption. It can be defined as a disorder characterized by fever coinciding with administration of a drug and disappearing after drug discontinuation. When no other cause for fever is evident after careful physical examination and laboratory investigation. It can occur in 3 to 5% of cases. Mostly, fever is not intolerable, but moderate biological disorders could be expected, including elevation or decrease in WBC count, eosinophilia, liver cytolysis, and increased C-reactive proteins. Now we will see few symptoms and diagnostic factors of drug fever. A fever is one of a cardinal sign of infection. The presence of fever in any patient could raise a question of being infectious or non-infectious. They can be differentiated on the basis of clinical signs and symptoms, the degree of temperature elevation, the relationship of fever with pulse, and time of fever occurrence. The more susceptible patients are those who have history of allergy of one or more medication, or they can be taking sensitizing medication for months or years. Patient having drug fevers physical examination shows temperature less than 102 degree Fahrenheit. Normally, the pulse rises with increase in temperature. For every degree Fahrenheit temperature is increased, the pulse should rise 10 beats per minute. If it is not there, it indicates relative bradycardia. Also, patient doesn't show any uneasiness for such high fever, and there is no rash present. If rash is there, it is drug rash, not drug fever. Laboratory test shows increased WBC counts, increased eosinophil due to hypersensitive reaction, and elevated erythrocyte sedimentation rate, or mildly elevated serum transaminase due to damaged liver is also there. We'll start with case study. MM, a 47-year-old ill-appearing woman, is hospitalized with 3-day history of difficulty breathing, left-sided chest pain, and on inspiration, fever, chills, and productive cough. Her medical history is significant only for hypertension, and she has no drug allergies. MM physical findings on admission are temperature 100.4 degree Fahrenheit, respiration 20 breaths per minute, and left-sided crackles heard on oscillation. Oxygen saturation is 85% on room air and heart rate 85 beats per minute. A chest radiograph reveals an infiltrate in her left lower lobe. Her WBC count is 17,500. Community-acquired pneumonia is diagnosed, and MM is empirically started on ceftriaxone, azithromycin, and oxygen. Other medications include oral acetaminophen, oral famotidine, and oral hydrochlorothiazide. 72 hours later, MM is breathing without pain at respiratory rate of 12 breaths per minute. Her lungs are cleared to oscillation, and her oxygen saturation is 98% on room air. She appears much better and offers no new complaints. Her temperature over previous 48 hours has ranged from 101.48 degree Fahrenheit to 104 degree Fahrenheit. Her pulse has ranged from 90 to 100 beats per minute, and her WBC count is 22,000 with following differentials: PMN 89%, band 5%, lymphocyte 12%, basophil 0%, and eosinophil 7%. Drug-induced fever is considered. Few questions were asked. What evidence support this diagnosis? What is mechanism for drug fever? What agent is most likely cause of drug fever in MM? And how should MM drug fever be treated? Can MM receive cephalosporin in the future? To solve the case study, we'll start with subjective. Gender of female, uh, gender female, age 47-year-olds. History of hypertension, well controlled on hydrochlorothiazide, and no history of drug allergies. Chief complaint is that she has community-acquired pneumonia and elevation in temperature is recorded during 48 hours. Onset of temperature rising is 24 hours after medication is given. Current medication due to pneumonia empirically started on ceftriaxone, azithromycin, and oxygen at 2 liters per minute. Other medication include acetaminophen, famotidine, and hydrochlorothiazide. Her vitals on admission were temperature 100.4 degree Fahrenheit, heart rate 85 beats per minute, respiratory rate 20 breaths per minute, and left side crackles heard on oscillation. But after 72 hours examination, temperature over 48 hours 101.48 degree Fahrenheit to 104 degree Fahrenheit, heart rate 90 to 100 beats per minute, respiratory rate of 12 breaths per minute, and lungs are clear to oscillation. Her laboratory test on admission shows WBC counts 17,500 cells millimeter cube with PMN 83%, bands 12%, lymphocyte 10%, and basophils 0%. Eosinophils 1%. Examination after 72 hours shows increase in WBC counts 22,000 cells per millimeter cube with increase in eosinophils to 7%. As you can see, there is an elevation of WBCs, especially eosinophils. Assessment of MM's case shows that her improvement shows improvement in her pulmonary status even with high-grade fever. Also, there is leukocytosis. She doesn't show any uneasiness as that would be expected in case of any untreated infection. The WBC's count should decrease as her respiratory function is improving, but they are elevated. Particularly, her eosinophil counts has increased, which is an important diagnostic factor found in hypersensitive reaction. Despite her high-grade fever, she has relative bradycardia. The timing of increase in temperature is within the days of starting new medication. All these factors are evident towards the drug fever, but a clear diagnosis can be made only after stopping the suspected medication and fever is resolved within 48 to 72 hours. Drug fever can be difficult to diagnose and can be misjudged as a new infectious disease or failure of response of the current treatment. It is important to realize all these factors. Mechanism of drug fever. Mainly, it is hypersensitive reaction. Other mechanisms include pharmacological action of drug, altered thermoregulatory function, decreased sweating due to anticholinergic drugs, drug administration related fever, and idiosyncratic reactions. Few medications cause drug fever, mainly include penicillin, cephalosporin, anti-tuberculars, anti-arrhythmic drugs, antihypertensive drugs, and anti-epileptic drugs. Also, we have found evidence in literature about anti-infective class, especially beta-lactam antibiotics, antihistamine, except diphenhydramine, anticholinergic drugs like tricyclic antidepressants, anti-neoplastic drugs like asparaginase and bleomycin, vasodilator that is hydralazine, drug containing sulfonamide moiety, including antibiotics, stool softener, and diuretics. In case of MM, cephalosporin or macrolide is most likely causing fever, as acetaminophen and famotidine rarely cause only fever without any other allergic reaction. Treatment of MM is that MM antibiotics should be stopped and simultaneously her temperature, WBC counts, heart rate, and respiratory status should be followed. For her pneumonia, an antibiotic from other class like fluoroquinolones should be started to complete a 7 to 10 day antibiotic therapy. Precautionary advice is that, as in case of any other hypersensitive reaction, re-exposure to offending drug can cause similar response. Maybe the degree of response is same or it could be greater. In case of MM, re-exposure to ceftriaxone or other beta-lactam antibiotic or macrolide might cause febrile reaction. It is not clear that how large the risk of re-exposure would be, so it should be avoided. If MM has to take such drug in future, it is necessary to administer the drug in monitored setting. That brings us to the end of the presentation. I'd like to summarize by saying that the drug fever may not be a common disorder, but few drugs like antibiotics, antihypertensive, or anti-epileptic may cause the fever without showing any other symptoms. Drug fever is challenging to diagnose, but a thorough analysis is required to detect this disorder. Drug fever may not have a specific drug therapy. It is mainly managed by ceasing the suspected medication with continuous monitoring. I have provided references for the above material. Thank you. That was all about drug fever and its case study. Thank you for your interest and attention.